Hi everyone, I want to talk about ankylosing spondylitis. Ankylosing spondylitis. Okay, let's go. Ankylosing spondylitis is an autoimmune disease affecting the sacroiliac joints and the vertebrae. It affects entheses, that is the site where tendons or ligaments will insert into the bone. That leads to enthesitis with inflammation, osteopenia, erosion, ossification, and Syndesmophytes, that is osteoproliferation. Epidemiologically, more males will be affected than females at the ratio of 3 to 1 respectively. It is milder in females, even though they are less affected, so they are pretty lucky. Females are pretty lucky when it comes to ankylosing spondylitis. HIV-B27 is present in about 90 to 95% of the affected individuals. The onset of this trouble is in the 20s, and the sites affected, like I've just mentioned, will be sacroiliac joint, can affect the hips and vertebral inflammation known as spondylitis, and the shoulders are not left out. The clinical features are extra-articular manifestations of ankylosing spondylitis will involve aortitis, aortic incompetence leading to aortic regurgitation. There's possibility of arterial uveitis and ulcerative colitis. Some will have atlantoaxial subluxation, apical lung fibrosis, and amyloidosis. When there's amyloidosis, that will affect the kidneys and the brain, even leading to dementia. Still on clinical features of ankylosing spondylitis, it's likely that the individual will have postural changes. And with that, there will be increased occipital to wall distance, increased cervical flexion, increased thoracic kyphosis, and decreased lumbar lordosis. There's possibility of Coller equina syndrome. In that case, it's going to be acute emergency, and there's possibility of apical fibrosis in the lungs, aortitis, I've just mentioned that, pericarditis, conduction disturbances, heart failure, IgA nephropathy, large joint arthritis of the lower limbs, enthesitis of the tibial tuberosity, and enthesitis of Achilles tendon, and of course plantar fascia insertion into the calcaneus. Still on clinical features, the morning stiffness in ankylosing spondylitis will be greater than 1 hour. There's likelihood of back stiffness, and they may have pain at night. They will have pain at the buttocks, and that is going to be continuous in nature. The sacroiliac joint is not spared with pain, and range of motion will be decreased. When you do your scuba or modified scuba test, it's going to be positive. As a matter of fact, that is the main test we do on physical examination when a young man or woman presents with sacroiliac joint pain and we're suspecting ankylosing spondylitis. Modified scuba test. The investigations will involve the X-ray of the sacroiliac joint and the X-ray of the entire spine, giving a kind of bamboo sign on X-ray. The MRI of the spine could be done at the centers where that will be readily available. The treatment will involve exercise, physiotherapy, breathing exercises because the lungs are not spared, and pharmacologically we can give non-steroidal anti-inflammatory drugs, the ibuprofen and the rest, but watch out for the side effects and effects on the cardiovascular system. Glucocorticoids should be administered topically or local injection, particularly in case of uveitis. Disease-modified anti-rheumatic drugs like methotrexate or sulfasalazine will be welcomed, and anti-tumor necrotic factor. Surgery will involve hip replacement, osteotomy of the vertebrae, and spondylitis. The prognosis is such that there will be remissions and relapses, and that is very common. The individual will have intact functions, they are still capable of daily activities, and when females are affected, like I've said earlier, it is milder in them, so the situation is better in females. Better if the onset is greater than 40. Worse if the individual is having the disease earlier in life, that is, early part of the 20s. And when the hip is involved, then the prognosis is worse. In conclusion, when you find an autoimmune condition, look for the rest. For example, we are dealing with ankylosing spondylitis here, and part of the extra-articular manifestations was ulcerative colitis. Imagine that, and aortitis, leading to aortic regurgitation and amyloidosis. Now, I would be suspicious. What is happening to the glucose there? Is now pancreas being affected? I would like to check what is happening to the thyroid during thyroid function tests, thyroid stimulating hormone, because we may be dealing with Hashimoto thyroiditis also here. And what about rheumatoid factor, rheumatoid arthritis, and so on? So I want to know all this while handling somebody with ankylosing spondylitis. So when there is an autoimmune condition, look for the rest. Thank you for listening to my presentation. Kindly subscribe so that I can get these publications immediately they are released. Thank you.